I am Dr. Khalil Rahman, a consultant vascular surgeon at Trauma Center, Karachi. I am moderating a session or update in vascular and endovascular surgery. I may request Professor Tanveer Khalid, Professor Javed Nawab, Dr. Umar Hassan, and Dr. Zia Rahman to chair this session. Our first speaker of this session is Dr. Atif Sheraz. He is an interventional radiologist, CMH Rawalpindi. Dr. Atif Sheraz, please.
Bismillahirrahmanirrahim. Thank you very much for inviting me to this session. I'll be discussing AV malformations. My talk is basically designed for resident level. I'll be having a general overview of AV malformations. In the end, I will show you some cases. Right, so the International Society for the Study of Vascular Anomalies classifies vascular anomalies into tumors and malformations. So among these malformations, I will be basically concentrating on the AVMs. Right, so AV malformations are high flow, low resistance, abnormal communications between the arterial and venous systems with an absent normal capillary network. This is due to failure in resorption of primitive blood vessels during early gestational phase. AVMs have a high recurrence rate after endovascular or surgical treatment. So, as a radiologist, how do we diagnose AVMs? The typical features, initially we start from the Doppler ultrasound. We see high flow arterialized lesions. On MRI, the nidus is visible. As you can see in that black part, the pointer is not working. So an AVM nidus will be hypointense on all sequences. There may be a small associated mass because of the soft tissue proliferation, but generally there is no mass. And we see these in this dynamic MRI, we can see that the other leg, only the arteries have just appeared, and here already the veins are opacified because of the high flow. And the angiogram is the gold standard for diagnosis. We see the arterial inflow, the nidus, and the draining veins. So this is the typical angiogram of an AV malformation. So this contrast blush is the nidus that we saw. Right. I'll not be discussing venous malformation, but just for comparison, a venous malformation would show a heterogeneous serpentine appearance. The Doppler flow would not be high flow. There would be hardly any arterialization. Direct puncture will show these serpiginous vessels, and it will appear hyperintense on T2. A lymphatic malformation would be just cystic spaces with no vascularity. So just to recapitulate, this is a typical AV malformation. We see on Doppler the high flow, arterialized lesions, and the nidus. There is the hypointensity of the nidus on all sequences, a bit of soft tissue hyperplasia, thickening, not a proper mass, and on angiogram, the typical vascular blush. So clinically, AVMs are divided into phases. The first is the quiescence phase, where there is a cutaneous blush or warmth. Then expansile stage, where we have a bruit, audible pulsation, and enlarging lesion. And then the destruction phase, where there is pain, ulceration, bleeding, and infection. And finally, especially in case of large AVMs, the patient goes into cardiac failure. So, how do we treat it? The general approach to achieve nidus occlusion. The focus of treatment, the main goal of the treatment will be targeting and destruction of the nidus. The nidus is these abnormal vessels between the arteries and veins, and avoiding proximal occlusion. So we do not want to occlude the artery initially. We want to occlude the nidus. Partial occlusion or even partial resection of the nidus will result in treatment failure and possible enlargement of the AVM by neovascularization. Every effort should be made to avoid vascular compromise in normal vascular territories, and a stepwise approach with multiple sessions at regular intervals is recommended. In general, we rely on an endovascular arterial approach first to reach the nidus. This will allow inflow to decrease. Once this approach is no longer possible due to inadequate feeding artery size, the nidal destruction will be completed by direct percutaneous puncture or a venous approach. So basically the theme is that we should never tie the feeding vessel, we should never occlude the feeding vessel, and we should treat the nidus itself. Otherwise, it will take fresh blood supply from somewhere else. So this is a commonly used classification, which is the Chu-Do classification. In the first type, there is a nidus supplied by less than 3 arteries and a single outflow vein. In the second, there are multiple feeding arteries and a large vein, and then multiple arteries and multiple veins, and dilated arteries and veins. So what the recommendation is that in Chu type 1, we go for a transarterial or transvenous approach. In 2, we go for a transvenous approach. In 3A, a transarterial approach. And in 3B, we go for a transarterial, transvenous, or percutaneous approach. Practically, mostly what we are getting is 3A and B. So this is just a diagram to show one suggested method of going about it. Ultimately, depending upon the flow and the lesion, everyone makes their own decision what to do. So in a type 1 lesion, we are embolizing the feeding artery. In type 2 lesion, we are also occluding the vein because we have a large vein here and we are going through the artery. In type 3 lesion, we are occluding the vein and we are coming through the vein. The catheter is coming from the venous side and we are occluding the nidus. And in type in 3A and B, we are generally coming from the arterial side, followed by percutaneous. Right, so this is another commonly used classification, Yates classification. I will not go into detail. It's in the books. So what do we usually do? This is just an example. This is a AVM supplied by the branch of internal iliac artery. This is the feeding artery. This is the nidus, which is the blush of vessels. These are the early draining veins. Our microcatheter has reached the nidus, and after embolizing, we have this final picture where the whole thing is occluded. This is an example of a combined embolization strategy, transarterial and percutaneous, in a large right foot AVM. The patient had an ulcer also. So in this, the arterial inflow was closed with coils. It was rather reduced, and then percutaneously, the nidus was punctured and embolization was done. Right, so we generally use liquid embolic agents. Different embolic agents can be used to treat AVMs. The 3 commonest liquid embolics that we use are ethanol, ethanoline, vinyl alcohol, copolymer, and glue. So I will briefly be discussing each one of them. Ethanol achieves nidal obliteration by destruction of endothelium and thrombosis. For this to happen, the vessels must be exposed to alcohol for a certain amount of time. So inflow or outflow has to be managed. The outflow can simply be managed by simple compression also. Because of the risk of pulmonary hypertension, the recommended dose is 5 ml at one time, and we wait for 5 minutes before giving further injections up till a maximum dose of 0.5 to 1 ml per kg. But even that is a very high dose, and we have never given a dose that high. The amount of ethanol can be based on the amount of contrast medium required to fill the AVM nidus without opacifying the normal vessels. So when we do an angiogram, we decide that whether this nidus was filled with 5 ml or 3 ml or 1 ml, and then we give the same amount of alcohol. So this is an example of an AVM embolization with alcohol, a combined endovascular. This is the AVM endovascular approach with microcatheter, direct puncture with a 21 gauge needle, and then final satisfactory angiogram. Glue is one of the commonest agents used for nidal occlusion. It is mixed with the lipiodol, which is an oily contrast agent, and this combination will polymerize after its contact with blood or other ionic solutions, including sodium chloride. So when we are doing this glue embolization, we use 5% dextrose. The rate of polymerization depends on the lipoidal concentration. The greater the dilution, more lipiodol, the longer it will take to polymerize, allowing for deeper penetration. The ratio of glue to erythritol can range from 1:1 to 1:6 depending upon the distance from the catheter tip and flow rate. So we have to decide how fast flow the lesion is. If it is slow flow, we will give a different concentration. We want it to polymerize later. If it is faster, we'll decide accordingly. So this is Lipiodol. It is generally available in Pakistan, and glue is again very commonly available. We mix these and then we inject. The concentration of these will depend upon the flow rate. So this is an example of glue embolization. There is this AVM on the anyway. So this is the AVM, contrast opacified. We are giving glue through the microcatheter, through the 21 gauge needle, and this is the glue which has filled the nidus, and the procedure is completed. So as we mentioned initially, the aim of the procedure is to fill the nidus. Onyx. Onyx is the most useful agent for embolization of AVMs. The reason it is most useful is that it is very easier to control. It polymerizes slowly, and we have the learning curve is less. Glue can be very risky if it refluxes. So Onyx is a non-adhesive liquid agent that solidifies in blood. The solution is mixed with contrast material to provide visibility on X-rays to quickly check the degree of blood vessel blockage in between infusions. The viscosity of the agent can also be changed with less concentrated mixtures being able to penetrate further into blood vessels. Since it is non-adhesive, it does not stick to the catheter and allows for easier catheter removal after embolization. So one problem with glue is that once we are giving glue, sometimes it can stick to the catheter, and we have difficulty in removing the catheter. And there have been cases where the catheter was left there and it was simply cut where it came out from the sheath, and it was left inside the vessel. So if the glue sticks the catheter, there is very little we can do. But Onyx is very safe as far as this is regard. In this regard, the main problem is that it is much more expensive than glue. It requires DMSO compatible catheters. We give DMSO before to prevent polymerization. So not every catheter is compatible with DMSO. DMSO compatible catheters are more expensive. Now we have got some alternates slightly cheaper, which includes fill, squid, and lava. So fill and squid are available in Pakistan if somebody wants to use them. So this is an example of embolization of an AVM in the hypothenar region. The venous outflow has been occluded with coils, and Onyx has been given, and there is a good satisfactory result. The nidus has been obliterated, the swelling is reduced, there is no ulceration, there is no discoloration. Some new tips and tricks. Now we have got available in Pakistan also detachable tip microcatheters. So in a detachable tip microcatheter, if it sticks to the glue, that we can leave the tip in place and we can remove the catheter. So this is an example of a detachable catheter. The distal part, the two dots, this part can remain inside and is biodegradable. We have also got catheters with a balloon at the proximal part, so we can inflate the balloon and then inject, and this will prevent reflux. So we do direct punctures a lot because we find them easier, they're less expensive. So to achieve direct puncture, ultrasound guidance is used. Doppler waveform analysis helps target the proper vessel. Due to location at the boundary between artery and vein, these vessels show the most turbulence. For lesions that involve distal limbs, such as fingers and toes, tourniquets can be used to protect the tip of the digit if it is not affected, and also the other non-affected digits in proximity for protection if reflux occurs from an aggressive injection. So here we are treating an AVM. The AVM is being occluded, and we have tied a tourniquet to the thumb so that the embolic material does not go there, because once it goes to the tip, we will have gangrene of the thumb. So I'll show you some cases. This is first case is a large groin AVM supplied by branches of internal iliac artery. So this is our catheter showing the large AVM and the draining veins. So we took now we are injecting the glue into the nidus, and the glue is settling in the nidus. This is another feeder which we embolized later. And this is the final result. The nidus is gone. We can see the opaque glue in the feeding artery and in the nidus. So another case done by a colleague of mine, large wrist and thinner eminence AVM with multiple feeders. So hand is the most risky AVM to treat. So this is the feeder from the radial artery. It's very high flow. So we took the microcatheter as peripherally as possible. So in these patients, we try to use a very small microcatheter. We prefer Onyx, and we want to go as distally as possible because we want to avoid embolizing the fingers. So again, as distally as possible. So another feeder. So finally, there is some improvement. We can see the embolic material in some components of the AVM. So this continued. There are a lot of images, and we found that it is also supplied by the ulnar artery, and the same artery is supplying the blood vessels of the fingers. Right. The third case is a uterine AVM. So this is a large AVM in the uterus. We took our microcatheter to the uterine artery. It is in the uterine artery, and we can see the AVM outlined. We gave the embolic material, which is visible. We also gave from the other uterine artery. It was supplied by both uterine arteries. And finally, we have got all this embolic material inside we used glue in this patient. And foot AVM. So this was a large high flow AVM in the foot. We can see the feeding artery, the nidus, the large draining vein. And we went for percutaneous punctures one by one because they are safer. This is another percutaneous puncture into the nidus. And we can see that there's another feeder. So we kept on doing them. And in the last image, we have got a reasonable occlusion of the nidus. There is some residual part, but now the case can be surgically operated. Right, so what is my conclusion? Vascular malformations are developmental abnormalities which usually do not present before puberty. MRI with dynamic contrast enhanced sequences is the mainstay of diagnosis, and characterization of these lesions is the mainstay of diagnosis and characterization of these lesions, while the gold standard is catheter angiography. The identification of a nidus and its obliteration are key to treatment. Multiple treatment sessions and combined endovascular and surgical approach is required, and never tie the feeding vessel. Thank you.
Yeah,
Very nice, informative presentation. Any questions from the audience?
Two questions we have.
Yes, sir, please.
yeah. Two questions. So one of this is very splendid talk, and I really appreciate your work. And we, as a vascular surgeon, we have the problem in counseling. Patient come, they have a large AVM. The first question they ask, is it going to recur? Is it going to recur? So our answer is yes. And what is your approach? How you counsel the patient? How many intervention they demand? For example, you are showing an AVM on the wrist or on the foot. Does it totally obliterate, or there is a high recurrence rate, and how you prevent them up? Yeah.
Sir, when talking about the hand and the foot, we do a very meticulous counseling because these are very risky lesions. Ideally, they should be done with Onyx, but Onyx is very expensive, and many of our patients, they can't afford the multiple sessions and the Onyx itself. So we do it with glue. So it always requires a lot of counseling. Generally, we leave some nidus. We don't get too greedy that we want to obliterate literally everything. because it gets very difficult. The more we do, the more the risk of reflux into the normal vessels. So we do leave some of it for the surgeon to remove. And many of these cases, they go to the plastic surgeon afterwards, and generally they remove them.
So just for the sake of interest, what is the difference between the price of a onyx and the glue?
So glue is around 10,000 rupees. Onyx is 80,000.
Oh, there's a
And
significant difference.
The catheter has to be DMSO compatible.
Oh,
So DMSO compatible catheters are expensive.
yeah.
So that is
That is great work, actually.
Lipoidal 45,000.
Oh.
Which one is better for the patient?
So Onyx is much better, sir, because it is safer. Onyx polymerizes slowly, so we slowly push it into the AVM.
Yeah.
With glue, it's a very risky thing. It can reflux easily, and it may not fill it fully and polymerize early. So there's a very long learning curve for glue.
Yeah. Right. Hopefully, we have more time. We will ask questions and have interaction. Thank you for your time. Yeah.
Thank you, Dr. Atif Sheraz. Now I invite Dr. Sana Sharafat. She is a vascular and general surgeon at Kerala Hospital, Islamabad. She will present a presentation over artificial intelligence in vascular surgery. Dr. Sana.
Thank you very much. Bismillahirrahmanirrahim. As we all know that the properties of human intelligence are being exhibited by a broad spectrum that is discipline that focuses to design systems, which is named as artificial intelligence. Artificial intelligence has actually revolutionized the medical science by assisting physicians in clinical decision making. So today I'll be talking about applications of artificial intelligence in vascular disease management, and I'll be sharing with you our AI-based project with the name of Vascular Arterial Surgical Planning System that is funded by National Center for Artificial Intelligence and Higher Education Commission. So the aim of our project was to develop assistive technology using AI for the detection of peripheral arterial occlusive disease, and also to observe whether such models can perform better than the classical mode of diagnosis through the interpretation of CTA. So this is our project team hierarchy and introduction. Professor Tanveer Khalik, he is the principal investigator of this project, who is an ex-vice chancellor of Shahid Zulfikar Ali Bhutto Medical University and an HOD of Department of Surgery, PIMS, Pakistan. He actually conceived this idea during pandemic with the rise in cases of peripheral arterial occlusive disease, and the project was awarded to us by National Center for Artificial Intelligence as part of IT Initiative Program of Higher Education Commission. So our team included me, of course, as a vascular surgeon for the collection of cases, tagging of images, and bridging the gaps between the clinicians and the IT engineers, basically. Dr. Saida Kiran Riaz, she is also sitting with us right now. She is a PhD in molecular biology, and she did all the write-up and project management. Apart from that, there were two collaborators from ComSats and FAST, and our industrial partner, Zylexa, for the development of artificial intelligence software based on our input. The project was awarded to us in 2021 with a grant of 10 million, and it culminated in 2023 with the development of Vascular Arterial Surgical Planning Computer System, of which I'm going to share the details in the upcoming slides. We hired several radiologists and computer engineers and technicians for completing the assigned task. So we all know that in the vascular system, our main focus is on the arteries, as it has got grave consequences if not diagnosed and managed on the timely basis. And there's a huge network of named vessels that we already know of. Peripheral arterial occlusive disease, it actually makes up the major disease burden all over the world. And it is primarily caused by atherosclerosis, which is initiated by endothelium activation and followed by a cascade of events leading to accumulation of lipids, fibrous elements, and calcifications. The major risk factors are diabetes, smoking, hypertension, and hyperlipidemia. Plus, there is a recent increase in thromboembolism because of the COVID-19, because it actually damages the endothelial lining, leading to limb ischemias. The major vascular pathologies that we are dealing with these days is acute limb ischemias, chronic limb ischemias, aneurysms, carotid artery stenosis, and trauma. We have got three management options for them. That is, number one is the medical management, number two is the endovascular, and number three, we have got the open surgery. And we are doing different types of open surgeries for that. So basically, challenges in accurate diagnosis is actually the imaging in vascular surgery, which is actually the fundamental step in the management of these patients. And this imaging actually enables us the confirmation of the diagnosis, the evaluation of the prognosis, and the decision regarding the surgical intervention. The two images that we are using these days is CTA and MRA. So we wanted to develop a multivariable score by combining the clinical, biological, and the imaging characteristics of CT scans, and to classify the patient status, risk assessment of pre- and post-operative complications, and guide the surgeons to choose the most appropriate surgical technique. And this led to the development of our objective, and that was to investigate the primordial perception of AI and its potential applications in vascular surgery. So AI for peripheral arterial occlusive disease can detect the location of occlusive and stenotic lesions, the length and the degree of stenosis, the plaque characteristics, the development of collaterals, and the inflow vessels and the distal runoff. The degree of calcification, hemodynamically significant stenosis, and the presence of atherosclerosis can also be signaled by AI. As we all know, the more images you see, the more examinations you report, the better you get. The same principle works for machine learning as well, and in particular for deep learning. Artificial intelligence can facilitate peripheral arterial occlusive diseases by computer-aided detection with accurate and fast diagnosis, timely interpretation, and the planning of the surgical intervention. So here we have got vascular arterial surgical planning system, which is an artificial intelligence-based system, and it is capable of handling and processing real-world labeled medical data and provide valuable and accurate feedback to the surgeons and medical professionals to help them with the decision-making. Our system will be able to cater the following areas, that is the detection of the diseased area, percentage of the stenosis, length of the stenosis, and this decision support for the surgeons. So the following security protocols were modeled into the application's interactive side of things. Number one was data anonymization. So as per healthcare policy and standards, we anonymize the data to remove all the patient's data and identifier from the DICOM headers and share studies through secure cloud-based PAC system. So we have cloud-based central PAC system that is password protected and only shared with the relevant stakeholders. And this archive data with standard compression techniques. And finally, we have got local archive system as well. We also have copy on local archiving drives as secondary backups. This is the pipeline workflow. So for data acquisition, CT scans of more than 100 patients were obtained, from which our input layer, it took down the clinical, demographic, and imaging information. 124,286 slices of CTA of patients were tagged by trained radiologists and the surgeons for model training. Images were then processed and removal of artifacts was done. Machine learning models such as ResNet was used for the classification of the body into regions, and UNet architecture was used for the segmentation of different regions of the lower limbs. Deep model training, validation, and testing took place in our AI layer, which finally predicted the confirmation of the diagnosis and the planning of surgical intervention. So this is, again, the project flow for the development of vascular arterial surgical planning system. After data acquisition was done through the prospective and retrospective way, data was stored on the PAC system, then it was labeled, and then artifacts were removed, and then deep learning model training and validation was done, and finally model testing was done. CT scans were collected by the radiologists and the surgeons, and multiple filters were applied to give sharpness and smoothness to the images for improving the features. And the image fed into the system went through pre-processing for noise removal. And during the pre-processing step, we actually converted the DICOM images to the bone window. So frame by frame region identification was done, and region-wise bone tagging was used for the system, in which 5 major regions were categorized. So our main aim was we used actually the bony landmarks to detect the region of the body and the arteries. So 2 models of artificial intelligence were used, that is the classification model and the segmentation model, in order to identify whether the vessels are blocked or not, and to identify the diameter of the vessels. So here the green regions that you can see, so they are actually, they were predicted by the model and cross-verified with the study labels and radiologists. These are the vessels that are being highlighted by the segmentation results. So then this is the confluent matrix graph and statistics. After training the model, 6,415 slices were used to test the classification model, whereas 13,093 slices were used for the segmentation architecture. Models trained on the dataset of Pakistani patients outperformed stepwise logistic regression models obtained from the clinical reports of the same patients that were reported by the radiologist for the diagnosis of peripheral arteriocclusive disease. So both the classification and the segmentation models were markedly better calibrated than the stepwise logistic regression models. Our AI system showed 95% sensitivity for the diagnosis of stenosis in all the cases, while the percentage and the length of stenosis were variable in the test cases. It was almost 99% accurate for the aortic region, 96% accurate for the common iliac region, 93% for the external iliac, 97% for the femorals, and 89% for the popliteal arteries. The AI system also provided accuracy of 97%, sensitivity of 96%, and specificity of 99% of AI peripheral arteriocclusive disease algorithm for the segmentation model after statistical analysis in comparison to the diagnosis of the radiologist. So this is how our VAS platform will be working in the hospital setup. So in the hospital setup, after getting the subscription of vascular arterial surgical planning software, our cloud will be linked with the PAC system. And as soon as the CT angiogram will be performed, it will be fetched by cloud automatically for AI processing. And the report will then be available for the radiologist or surgeons for final review and comments. So this is a video. We have compiled a video for demonstration of our product VASP. Here you can see that you will get your login ID after purchasing the product license. You will get the DICOM viewer for uploading the CTAs, or it will be directly fetched from your PAC system. The slices will be processed in the software, and then you will get a report giving exact percentages and lengths of the stenosis in all the slices processed. These are the vessels that is being highlighted by the AI system. It's showing the diameters and everything. Then this is a patient information performer that has got all the demographic features, the clinical features, the pre-op Doppler findings, and these are the percentages of stenosis or the lengths of stenosis that it is showing. So this report will help the radiologists and surgeons in decision-making for further treatment. This is our commercial roadmap for project sustainability. We are still working on our minimum viable product. Team is working on data labeling, AI algorithms training, and cloud-based service to integrate with Xilexa platform. Initially, we have identified 3 pilot sites, that is PIMS Hospital, Advanced Diagnostic, and Kulsum International, for independent retrospective trials for 1 month to compile results for white paper. Association of Physicians of Pakistani Descent in North America, that is APNA, has signed an MOU for supporting our product approval and commercialization in USA. 1 article has been published, 1 is under review of European Journal, and 1 article is under preparation. Study has been presented in 3 conferences locally, that is at RMU, ComSats, and NUST. 2 white papers are under processing for publishing in relevant journal with the output statistics and configured matrices for the validation of the product. After successful pilot studies, we will launch our VASP service for the commercial trials to our customers with the CT angiography facility. Currently, the product of Xilexa is already being used in Pakistan, and globally, business development team of Xilexa will add VAP service in portfolio and reach customers as per plan. So this is the market analysis. So global artificial intelligence in medical imaging market is expected to rise from its initial estimated value of $21 billion in 2018, and is to a projected value of $264 billion by 2026. So therefore, an AI-based prediction model is a necessity for the diagnosis and timely management of peripheral arterial occlusive disease patients. This is our marketing strategy. So we will implement smart go-to-market approach and reach our customer through the following strategies. Participation in national and international conferences on vascular surgery, like the way we are doing today. Content marketing, then social media, search engine optimization, then through partner with national and global hospital labs, and finally organizing workshops and training for surgery residents. So in conclusion, it is the first of its kind AI-based computer-aided assistive technology developed on the indigenous data of Pakistani peripheral arterial occlusive disease patients. The AI peripheral arterial occlusive disease model has been trained to assist clinicians and surgeons in the interpretation of CT scans to detect the stenosis in the peripheral arteries and the formation of plaques in the lower limbs. Machine learning approaches can generate more accurate diagnostic tools in a time-saving manner, and these models can be used in clinics for the automated identification of patients with highly morbid diseases for which aggressive risk factors management can improve the outcomes. Thank you very much.
Thank you very much, Sana, for such an excellent presentation, and I must congratulate you and Professor Tanveer Khalik for coming up with this idea. And the presentation basically tells us all your journey from beginning to a plan to implement it to the end. And I'm really glad to see that you've used artificial intelligence not to replace us vascular surgeons, but the radiologist. So I'm sure there must be quite a lot of discussion. People must be eager to ask questions. Fareed?
Thank you, Sana. That was really commendable work. My question is, being a vascular surgeon, you said this is going to aid in clinics in decision making as well. So, being a surgeon myself, vascular surgeon specifically, until unless I see the image myself, I'm not very clear about my plan.
Mm-hmm.
So, what's your thought on it? How this is going to help us, the vascular surgeons? But I understand for the other colleagues.
Okay, I got your point. Actually, the thing is, being a vascular surgeon myself, what we do is that we see the patient from the very first step he took in our clinic, actually. So we know the history. We clinically examined the patient. Even we are doing our handheld Dopplers ourselves, and we are interpreting the CT scans ourselves. And after that, we are actually doing the surgeries, and we are seeing the power of findings and the results that we are getting out of it. The basic objective behind this AI system was that there was a lot of difference between the surgical opinion and the radiology opinion in interpreting those CT angios. So in this AI system that we have now actually trying to make, the CT angios were being reported by the surgeons themselves, the vascular surgeons, and they were being reported by the two other radiologists as well. And nobody knew the final answer of it. And then we actually added our pair of findings that were what we actually found after, a whole workup and everything. And then we, trained our AI system according to that. So that's why the results are far more superior than the surgeon itself or the radiologist alone. So it's a combined work of AI, doing the work for the surgeons and the radiologists as well.
Sana, it was an excellent study and an excellent idea and a really, truly an original work. So, well done.
Thank you.
Now, my question is that as a vascular surgeon, as Fareed said, that we are interested in knowing what should be our plan. And often we find that vascular disease is multi-segmental.
Yeah.
So I think it is going to take a very long report if there are numerous stenotic lesions spreading all over the vascular tree. and to write a report and then to interpret the report and start reading the report, and there will be probably 10 or 12 lesions with various lengths. So is that going to make a difference as far as the patient's outcomes are concerned? Or is that going to make me wiser? I mean, can this AI system remove calcification? And you said that we have compared the reports written by vascular surgeon and radiologist with the AI systems, and AI system is superior. But what is our gold standard? Have we compared it to the DSA? Because DSA is the gold standard. So it may turn out that actually the vascular surgeon worked better than AI. So what is your take on these?
Okay, so the thing it is still a pilot project that is going on, and the final aim or the objective of this, AI system is to actually tell the young surgeons about the treatment options, whether to go. I mean, that is the goal of this whole idea. That is going to tell the young surgeons about whether this patient should go for the medical management or the endovascular or the surgical options. Yeah, it's not going to, I don't think so. It's going to be very useful for surgeons like you who are already very experienced. So it is actually made for the young surgeons who are coming up in the market right now. And, especially if you are dealing with a vascular trauma or any vascular cases in the odd hours. So our AI system can actually help those people. I mean, 24/7 radiologists are not available in the hospitals. Yeah, so AI system can actually give a better idea to those young surgeons. As that's what I think. But as an experienced surgeon like you, I don't think so that it will be of more useful to you. And Dr. Kiran want to add something in it.
No. So we take the opinion of Miss Kiran. You are the doctor on the.
No, she's
She's one of the.
person.
Yeah, that is great actually.
She's a PhD doctor.
Very good. So it.
Real doctor.
Yeah, that is good. It shows a very good team approach. Yeah. Yeah.
You see, as a vascular surgeon, what you want? You want a very clear anatomy of the vascular tree, right? When you're operating, you are putting a graft, you are doing an endarterectomy. You need a very good abnormal anatomy, right? So what we were having, the problem we were having that depending on the report of the radiologist, I am not, unko main kam nahi kar raha radiologist ko, and reports seen by me, and the intraoperative findings were different, You see, the AI reporting was more accurate than the report of the radiologist and the surgeon. The study so far conducted, it is giving us better results. So when you are doing a FEMPOP bypass and radiologist says that the popliteal artery is patent, very good report, I've seen the report myself. There is a doubt that there is a flow. But when you open up as a surgeon and you find a stenosed and a popliteal artery full of plaque and calcium, you have to close down, So I think the report coming from the AI is not going to be the final report. It is going to complement the report of the radiologist and surgeon seeing himself. So give a better, roadmap for the surgery.
It is actually going to
Complement.
जी
नहीं
but I think it has a complementary role. So आप जो idea बनाते हो, आप हमेशा radiologist की report
नहीं आप अंडरस्टैंड नहीं कर रहे मेरा पॉइंट. रेडियोलॉजिस्ट का रिपोर्ट जो देगा ना, वो दैट विल बी a stenosis in narrowing, लेकिन ये जो रिपोर्ट देगा ना, एग्जैक्ट लाइन, लेंथ, डायमीटर एंड एवरीथिंग, ये बहुत एक्यूरेट देगा आपका.
Sir, that's why we are calling it an assistive technology.
जी, this is what I wanted to say कि this is an assistive technology for the radiologist. और सर जैसे अब पूरी दुनिया एडवांस कर रही है AI की तरफ, so why not us? क्योंकि पाकिस्तान का अभी हमको पता है कि इस वक्त नंबर 3 पे हम हैं IT टेक्नोलॉजीज़ को बनाने के लिए सब पूरी दुनिया में एशिया से. So जिस वक्त ये पेंडेमिक था तो प्रोफेसर तनवीर खालिक वाज लाइक कि क्यों नहीं कि जब हम आपको पता होगा कि पाकिस्तान के अंदर इस वक्त ब्रेस्ट मेमोग्राफी की रेडियोलॉजी के ऊपर और पैथोलॉजी पे काम हो रहा है. इट्स जस्ट दैट इन हेल्थ केयर. तो इसलिए फिर हमने ये टीम जब बनाई, तो अब आप देखें कि ये जो हमारे पास जो रिपोर्ट आ रही है, द सिस्टम इज जस्ट गोइंग थ्रू द पिक्सल्स. सो अब जो पिक्सल्स के अंदर उसको जो साइज मिल रहा है उसके हिसाब से हम उसकी ट्रेनिंग कर रहे हैं. सो अकॉर्डिंग टू द पिक्सल्स अब उसमें जितनी ब्लॉकेज होगी उसकी लेंथ और वो सारी एक, जिस तरह से सर ने अभी कहा कि एक बहुत डिटेल्ड रिपोर्ट जनरेट हो जाएगी. देन द रेडियोलॉजिस्ट विल सी, एंड जो रेडियोलॉजिस्ट का अपना भी काम था वो काफ़ी हद तक रिड्यूस हो जाएगा, क्योंकि उन्होंने जो सारी देख के रिपोर्ट बनानी थी वो एक्चुअल कंप्यूटराइज्ड फॉर्म में उनके सामने होगी. अगर वो उससे डिसएग्री करेंगे देन दे कैन ओमिट दैट पार्ट और दे कैन कंसल्ट विद द वैस्कुलर सर्जन कि ये वाली रिपोर्ट इसमें से है और इसके साथ हमें लगता है, देन पर ऑप वो चीज़. और जो अभी हमारा इसका पायलट के बाद जो इस वक्त ये कर रहे हैं कि पर ऑप फाइंडिंग्स को लिंक कर रहे हैं विद द CT दैट वाज. तो अगर कोई चीज़ जो कि पर ऑप भी नज़र आती है तो उसको भी फिर हम उसी CT एंजियोग्राम के अंदर इंक्लूड करें. सो दिस वाज द मेन आइडिया.
So we'll be adding such stuff as well. Yeah, inshallah. So we are working on it. It's just an idea that is coming up in the market.
इसको commercialize करने से we get more money and we get more deals.
Yeah.
This is we should take as a commercial model.
Because a number of companies they are interested in this.
Yeah.
Hopefully we will get some
Objections na karen rather.
So we can add DSA.
Yes. So we can take two comments. Okay, Dr. Alias, Mr. Dr. Sabi, and you want three, and then we actually yeah.
I think I must congratulate the team and Sana and everybody. It's great to see some original work, original research coming from Pakistan. Really, it's commendable.
Thank you, sir.
And I don't know how it's going to impact the vascular surgery and the vascular practice, but we have seen a few years ago, research came up about the mammography comparison with the radiological report, and there were least number of cancers missed by the AI compared to the best radiologists in the world. So AI has already surpassed the human brain, and but we have to see how it's going to impact the vascular surgery.
Thank you very much, sir. Thank you very much for the encouraging comment.
The project of mammography in breast AI that was also done
in this university.
Thank you. Wonderful presentation, Sana. Obviously, we cannot understand AI is here to stay. This is the era of AI. AI is going nowhere. In one form or another, AI is going to be incorporated here. But questions of validity will remain.
Yeah, definitely.
And how can we ensure correct validity? By having a larger data pool, which is accurately studying with your software is supposed to be studying. So my practical question for all of the attendants here is, which data pools can we contribute to? We are all working. Which open databases can we contribute to, and how can we contribute our images, our scans, our DSA findings, and which will be impactful towards this? If you can educate us on this, please.
Okay, so what we can do is that we can actually share the patient performance and the NGO reports, the NGO CDs that you can actually share with us, so that we can feed that in our AI system and software to check what exactly happened and how we interpreted it, and what were your per-op findings and what were your preclinical findings in that case. So we can compare it, and yes, you're right. If we are going to add more data into it, the accuracy, sensitivity, and the specificity of the whole software is going to increase.
So maybe you need to increase data collection.
Definitely.
Include more people.
So, सर जो आपने जैसे मैमोग्राम्स की बात की, तो इस वक्त इंटरनेशनली मैमोग्राफी का काफ़ी डाटा अवेलेबल है ऑनलाइन. देयर आर मेनी डाटाबेसेस जिसके ऊपर टैग्ड डाटा अवेलेबल होता है, और पाकिस्तान से या दुनिया से कोई भी जो साइंटिस्ट हैं AI बेस्ड, तो वो उसके ऊपर काम करके अपना प्लेटफॉर्म जनरेट कर सकते हैं. जब हमने ये काम करना शुरू किया था तो इवन वी डिडंट नो कि हमने इस जो हमारे पास एक CT एंजियोग्राम आ रहा है, इसको हमने कन्वर्ट कैसे करना है इस तरह से कि इसको हम इमेज को टैग कर सकें. तो वुड यू बिलीव कि हमने उसको सिंपल इमेजेस के अंदर, जैसे पेंट की इमेजेस की होती हैं, उस तरह से हमने इनिशियली उसको पहले कन्वर्ट करके उसको हमने खुद से कलर्स जनरेट किए इन ऑर्डर टू, जैसे अगर एक मशीन को आप बार बार एक डॉग की इमेज दिखाएंगे तभी जाके वो फिर प्रिडिक्ट करेगी कि ओके दिस इज़ द डॉग एंड दिस इज़ द कैट. तो इस तरह से हमने वेसल्स को हमें वो करना पड़ा. सो दिस इज़ द फर्स्ट इंडिजिनस डाटा ऑफ पाकिस्तान जो कि अब हमने इस्टेब्लिश कर लिया है ऑफ 100 पेशेंट्स. और ये भी आसान नहीं था। ये प्रोफेसर तनवीर खालिक और डॉक्टर सना की बहुत बड़ी कंट्रीब्यूशन है। वी आर गोइंग टू मेक अ वेबसाइट ऑफ आउट ऑफ द शहीद जुल्फ़िकार अली भुट्टो मेडिकल यूनिवर्सिटीज़ वेबसाइट के, जिसके अंदर हम चाह रहे हैं कि फिर हम इस डाटा को फ्रीली अवेलेबल करें बाकी जो साइंटिस्ट हैं उनके लिए भी इन द कमिंग ईयर्स, और भी जो लोग कंट्रीब्यूट करना चाहते हैं, क्योंकि जाहिर है कि अब इसके अंदर टेस्ट केसेस होंगे। अभी तो ये एक जनरल, जिस तरह से हम लोगों को जो एक जनरल केसेस थे उसके ऊपर बना है, फिर आगे टेस्ट केसेस भी इंक्लूड होंगे। तो दिस इज़ अ वेरी गुड आइडिया कि जिसके ऊपर हम कुछ इस तरह के कोलैबोरेटिव काम भी कर सकें कि अगर कोई और अपने केसेस हमें ऐड ऑन करना चाहें तो वो फिर हम उसमें ऐड करें।
So, excellent presentation. I have just one question. The whole process that you explained, that the AI will be trained like this. This is how we are trained as general surgeons during as vascular surgeons during our residency, then during our initial years as consultants. So if this system is provided to every resident, as you said, it is for the residents and the junior consultants, how will it impact on their development and growth as vascular surgeons? So does this consideration have been given?
The things will be made more easy for the young surgeons, obviously. So yeah, so if you're asking about the training purpose and everything, I think we'll stick to the basics. So they have to interpret the CT angels themselves, and then they can test it with the AI whether they were right or not.
So we humans are basically very lazy creatures. If a facility is given to us, we will rely on that more.
I know.
Human nature.
So, just
I think thank you so much, Sana and Kiran, coming over and presenting this very important. I think this is the beginning.
Thank you very much.
You see, we need more time. So the getting the money from HE was a great challenge. You know, it was a big project, and then 100 and kitne slices the, kitne images the, 150,000 slices. Basically 100 patients the, but concentrate on the number of the pictures. You see, that was a very, very tedious job.
that is start a very great discussion. So we conclude this session now. And a big clap for this.
Thank you, Chairs. Now I invite Dr. Umar for next session for moderating.
Good.